For chapter three, Introduction to Basic Pharmacology, it also has some information about other therapies, which we won't be going over in this class. One of the therapies includes in there is physical therapy, which we will be going over in a lot of classes. But it's really only about 6 pages on basic pharmacology. And what we really need to know is the adverse drug effects, the potential adverse drug effects, and how to recognize adverse drug effects. So we will, as we go through different pathologies for different systems, we will talk about drugs that are used to treat that and what they're used for. And when we talk about cardiac disease, particularly, we will talk about cardiac drugs. And then again next year in 2025 in 280, which is special topics, we will talk about cardiac rehab again, and we'll review cardiac medications. So this is something that even though we don't prescribe medications or advise changes in medications, we still have to know about them. So for the learning objectives, common terms, we need to know the terminology for pharmacology, differentiating the types of adverse drug reactions, and the factors that determine dosing schedule and blood levels of a drug. And we'll talk about different methods for delivering the drug to the body and how it's eliminated from the body. There is a supplemental lecture that has a little more detail on the pharmacology if you're interested. If you're not, then just don't look at that. It's not a lecture. I think it's interesting, but you know me. Okay, here we go. So pharmacology, it is integrated medical science involving chemistry, biochemistry, anatomy, physiology, microbiology, and more. Of course, that's why it's interesting to me. It's the study of drugs and their actions and dosage and therapeutic uses and adverse effects. So drug therapy is directly linked to the pathophysiology of a particular disease. So if the pathophysiology is caused by a certain thing, they try to target a drug therapy to change that thing. So we'll talk about that a little bit more in a few minutes. So drugs come from all sorts of sources. They can come from natural sources like plants, animals, microorganisms. Drugs can be synthesized from chemical processes, and they a lot of times from natural sources, they figure out that there's a certain source that can be derived from a natural product, and then they take it through a chemical process to derive that and to make it consistent. So that's really a really important part of pharmacology, is being able to consistently deliver the active compound that is linked to the pathophysiology of the particular disease. So drug therapy can do lots of different things. It can promote healing, like anti-inflammatory drugs promote healing by reducing inflammation. It can actually cure disease, antiviral or antibacterial medications where you already have the disease and the medication cures it. It can slow or control the progression of a disease. So cancer chemotherapy is an example. It can slow the growth of the cancer. It can slow the progression of the disease. A lot of medications that are used for long-term degenerative neurological diseases like MS slow the progress of the disease. They don't cure it, but they slow the progress so you can live a fuller life. They can prevent disease, like a vaccine can prevent disease. You don't get it in the first place. That's nice. Um, Drug therapy can alter neurotransmission. So antidepressants are a good example of this. Most antidepressants are selective serotonin reuptake inhibitors, or SSRIs. So they, like Prozac and Zoloft, those type of things. And so what they do is they extend the time that the serotonin persists in the synaptic cleft, so you get more use out of it. So usually the neurotransmitter is released into the synaptic cleft. It has its effect on the next neuron, and then it's taken into the cell and recycled. So, made into new neurotransmitters. So the SSRIs, make they slow down the reuptake, and so it persists longer and can have a longer effect in the synaptic cleft. Drug therapy can decrease the risk of complications. Anticoagulants are a good example of this. So sometimes a post-surgical complication is a DVT, or deep vein thrombosis, clot, if you like. And anticoagulants decrease the risk of that. The thing with anticoagulants, though, is you have to be the right amount, like everything, it's homeostasis, right? It's the balance. You have to be the right amount anticoagulated, not too anticoagulated, because then you'll bleed out, and not too little anticoagulation, or you'll clot. So you have to have that homeostatic balance. Drugs can increase function and comfort. So analgesics for pain. That's an example of just something that decreases your discomfort, increases your function. Replacement therapy, like insulin replacement or any kind of hormone replacement therapy. Reducing excessive activity in the body. So proton pump inhibitors like omeprazole, or Prilosec is the over-the-counter name. They inhibit activity of the proton pumps in the stomach, so they decrease stomach acid, so reducing excessive activity in the body. Pharmacology includes a lot of disciplines. Pharmacodynamics is examining the drug-induced responses of physiologic and biochemical systems. So what is the response that the drug causes? Pharmacokinetics is how the drug moves through the body and where it accumulates in the body after administration of the drug. So kinetics, it's like how it's moving through the body. Pharmacotherapeutics is how do you choose the right drug for disease prevention, treatment, or diagnosis? Toxicology is the body's response to drugs, particularly with regard to harmful effects, mechanisms of actions, symptoms, treatment, and identification of the toxic effects. Pharmacy is the preparation, compounding, dispensing, and record keeping of therapeutic drugs. So lots of different disciplines of pharmacology. I go into a little bit more in the supplemental lecture about how a drug makes it to the market, and in what stages it has to go through in the research. Kind of interesting. And I also talk about the role of therapy, the role of pharmacology in therapy. But the effects of drug therapy, usually there's a therapeutic action, a desired action of the drug that we want it to do. There can be side effects or non-therapeutic actions, but usually the desired action can be stimulating or inhibiting cell function. So we're talking about pathophysiology. We're always talking about what are the changes to the cells. We might need to stimulate certain cells and inhibit other ones. It's usually not it's usually or. Or blocking biochemical actions in tissues. So reducing the amount of acid in the stomach by decreasing proton pump action in the stomach, those proton pump inhibitors. Drugs are usually classified by their primary pharmacologic action and effect. So we have diuretics and antihypertensives and calcium channel blockers. So we say, what's their primary action in the body? Indications are approved uses of the drug to treat conditions for which the drug has been proven to be effective. So that is the research process and the testing process before a drug gets released on the market. Generally, drugs possess more than one effect on the body. We have the primary therapeutic effect that we're taking it for, and then we have those nasty little side effects. We don't like them. And when it used to be that drug companies could not advertise prescription drugs on television. They were restricted from doing that, and they were trying to get that to happen because they wanted to increase their sales. And so it was in the early 90s that started becoming to be allowed. And the stipulation was that they had to list all of the side effects or potential adverse or toxic effects in the ad. And so that's why you see the ads may cause this, because they're required by the FDA to list all those undesirable effects. So side effects are usually mild undesirable effects, even at the recommended dose. So when they say like, oh, may cause weight gain or itching or something like that. So that mild, not life-threatening effects. Adverse or toxic effects are dangerous effects that cause significant tissue damage and or are life-threatening. So when you see ads on television for drugs, you hear different ones, they go, may cause certain types of neurological disorders or something like that. That's a toxic effect. A side effect is the mild undesirable effect. So kind of make that distinction in your mind between side effects and adverse or toxic effects. So specific adverse drug effects, hypersensitivity or allergic reactions. So reactions can be mild or they can result in anaphylaxis, which can cause shock that can actually kill you. And in chapter 7, we'll talk about anaphylaxis, the chemical process of it, and how it can kill you. But that's a pretty serious effect because it could, stop you breathing. Idiosyncratic reactions are when an individual person has an unusual response to a drug. So they have a response to the drug that maybe wasn't observed during the testing period. And so they have an idiosyncratic usually means like unique, individual. And if you're one of those people that has idiosyncratic reactions to drugs, you might be a little cautious about taking on a new prescription or non-prescription drug. So that you could just have a reaction that's not cataloged yet. Iatrogenic, um, remember we talked about iatrogenic disease is a disease caused by medical treatment. So it's a negative effect associated with the administration of a drug. So there are some drugs that may cause diabetes or may cause some other disease besides the one you're treating. And you have to do sort of a cost benefits analysis. Is it worth it to take that drug, considering the potential iatrogenic effects? Teratogenic is a harmful effect on the fetus or developmental defects if taken by the mother when she's pregnant. So a lot of drugs will say not to be taken if you're pregnant or nursing, that sort of thing, because you don't want to do anything that's going to harm the development of the new person. So drug interactions are where a drug effect is modified by combination with another drug. So there are different kinds of drug interactions you can have. One of them is synergism, where the effect of the drug combination may be greater than the sum of the effects of the individual drugs. And you'll hear about different, like movie stars or whoever that were getting prescribed this drug and this drug and this drug, and they took them all together and died because the combination effect of the drug was greater than the individual drug effects all summed together, and that's synergism. That's not good. Obviously, it's additive plus. So it's not just the effects of the individual drugs added together. You also get an amplification of effect. Antagonism is where the combination of the drugs greatly decreases the effect of each drug. So sometimes you will say that you have an infection and you get prescribed an antibiotic, and they say that you should take it with food or you shouldn't take it with food, or don't take it with dairy products because it greatly decreases the effect of the drug, or don't take with certain other drugs. And you'll see a lot. If I like to, because I'm a nut, I like to read the labels of over-the-counter medications and prescription medications, read the information on the manufacturer's website. And they'll say what if they're known antagonistic effects from certain other drugs. So pretty interesting. Potentiation is where one drug enhances the effect of the second drug. And that may sound a lot like synergism, but potentiation is usually a wanted enhancement, and synergism is an unwanted enhancement, if you want to think of it that way. So potentiation is like, say that you're on Cinemet, which is the commercial name for carbidopa levodopa, which treats Parkinson's disease. And you also take a drug that is a dopamine agonist that enhances the effect of your carbidopa levodopa. You get a longer effect and less on-off times. So that's potentiation, where the two of them together enhance each other, but not in a negative way. And synergism is where the two of them together have a greater combination than the effects of the individual drugs. So you can sort of think of it as bad enhancement versus good enhancement. So hopefully that helps. So the dosage of a drug is the dose, the effective dose is the amount of drug required to produce the desired effect in an adult. And it's usually expressed by a weight or measure and expressed by a time factor. So you take 10 milligrams twice a day, something like that. For a child's dose, they usually calculate it by the child's weight rather than their age, because I'm sure you've seen this before. You see like a 2-year-old and another 2-year-old, and they're completely different sizes. It's just like this one's huge and this one's tiny. And eventually it evens out when you're in high school or whatever. But it's best to calculate by the child's weight and not the age. Some drugs can have different effects in males versus females. So that's something to know as well. In, I don't know, a while ago, the FDA came out with a warning that Tylenol, acetaminophen, has a greater harmful effect on liver in females than in males. And so they reduced the recommended dosage for females. So sometimes that is an effect. A loading dose is where you initially take a larger dose to raise the blood levels to an effective level quickly, because there has to be a point where you're like, you start taking it and the blood levels going up and up and up until it becomes effective, till you're at that effective level. So sometimes they'll give you a loading dose to get you up to that level sooner. So the frequency of dosing, like how often do you have to take it to maintain effective blood levels without reaching toxic levels? So the pharmacologist has to come up with an optimum dosing schedule for each drug based on the absorption, the transport, and the half-life of the drug. And the half-life of the drug is how quickly is it eliminated from the body. So the timing is usually specified on the prescription. And if you get a new prescription, a lot of times you go in the pharmacy and they say, oh, would you like to have some counseling from the pharmacist? And you go, yeah, tell me the skinny. And they come out and they tell you timing related to meals and daily events and sleep. Like, don't use before this, don't use after this, or make sure you take this on an empty stomach, or make sure you take this on a full stomach. Make sure you take this before sleep or after sleep. The optimum dosing schedule to maintain the effective levels of the drug without reaching toxic levels. That's the key. So if you are taking too much, if you're taking the doses too close to each other, you're not enough space of time between doses. That's the chart on the top. And you get up to an unsafe blood level of that drug. If you are taking it at regular intake with normal distribution and excretion, or another way that you could get that is not if you're necessarily taking the doses too close, if your body is not eliminating the drug effectively, so it's not, so maybe you have a kidney issue, you're not excreting the drug effectively, you could get to a dangerously high blood level because you're not excreting at a normal level. So the ideal is the bottom left, where we're maintaining a desired blood level, but we're not too low to be effective, and we're not too high to be unsafe or toxic. If doses are irregular, which is the bottom right graph, you might be in the effective range some of the time, but a lot of the times it's either too low to be effective or too high and borderline toxic. So the interval that you take the drugs at is pretty important. And for some drugs, it's extremely important. And for some of them, it is mildly important. So that's information that your pharmacist can give you. And a lot of times, if patients ask me, they say, oh, I'm taking this and that, and I'm taking it this many times a day. Do you think I should take it more often? My answer is always, it would be a good idea to consult your doctor about that. Because they're working with their doctor to try to figure out, or say we're working with someone who has Parkinson's disease and we notice that they have really severe on-off times on their medications, we might recommend to them that they talk to their doctor about adjusting their dosage. I'm not going to recommend what the adjustments are going to be, but just recommend do that referral. So a lot of times we need to know about things so we can make that appropriate referral. There are times even when we will contact the doctor and say, hey, such and such patient is telling me that they're having this effect, and they are going to be calling you about possibly adjusting their dosage, just to let them know that you talked about it with the patient. And then if the patient doesn't call, they know to follow up with the patient as well. So just that, our role in it is keeping the communication going within the medical team, keeping the patient informed about when they should be contacting their doctor, and monitoring for adverse effects. So that's really our role in it. Even though we're not prescribing, we're not changing. And if they say, oh, do you think I should stop taking it? I say, talk to your doctor first. Don't ask me. Not don't ask me, but it's not my role to recommend that one way or the other. So your doctor's the one you need to talk to. So lots of factors can influence the blood levels of a drug. Like I was saying, if you're not excreting appropriately, you can have higher and possibly toxic levels of a drug. So if you have reduced liver or kidney function, so liver is affecting the absorption and kidneys are affecting the excretion of the drug. So reduced liver or kidney function can cause you to have higher levels of the drug in your system, or lower than effective levels if if the liver's not absorbing it. Circulation and cardiovascular function, certainly, because remember the circulatory system, the fluid system is the information superhighway of the body, or it's the superhighway of the body. And so if you don't have adequate circulation or cardiovascular function, you're not going to be getting the drug to the appropriate areas where it can be effective. Age, because everything messes up when you get older. Not really, but it can affect it. So as you're older, you might have reduced liver and kidney function, and that's going to affect things. And you might have reduced circulation and cardiovascular function. If you're on the other end, if you're young, you might have different absorption because you have a higher metabolism. So very important. Body weight and proportion of fatty tissue. So someone who is living in a larger body and has a higher proportion of fatty tissue might have a harder problem circulating that medication around in their body. It affects their circulation and their cardiovascular function. Activity level and exercise. If you're exercising an extreme amount, you might be excreting the drug faster, and you might not stay at that effective level as long. Food and fluid intake. You can see how that would affect things. Genetic factors. Sometimes when you have an idiosyncratic reaction to a drug, it's just your genetic makeup. It's just that's your reaction to the drug. But also other genetic factors can influence the blood levels of your drug. Your health status and the presence of other chronic or acute diseases can definitely influence the blood levels of the drug and how it is broken down and distributed throughout your body. So drugs can be administered to act locally or to have a systemic action. So we'll talk about methods for introducing the drug into the body. But we'll just say the drug enters the body by the chosen route, and there are reasons for doing one over another. And it's absorbed into the blood or it acts at the local site. So say you're doing a transdermal over the skin drug interaction that's absorbed. It might be acting locally, but it might be absorbed into the blood and have a systemic effect too. So once it gets into the blood, it travels in the bloodstream, it arrives at its site of action, and it exerts its effect. Then it is metabolized into inactive compounds and it is excreted from the body. So this is like best case scenario, right? This is how it's supposed to work. If any one of those systems is messed up, it can mess up the whole system and how your body reacts to the drug. So lots of different ways to administer drugs. Oral, tablet, capsule, or liquid. That's a common way. I mean, if you take vitamins or anything, you usually take a pill, an oral tablet. That's a pretty easy way to administer drugs. It's inexpensive, doesn't require specific equipment or skills. The only skill it requires is being able to swallow, which some people can't. So if people have swallowing issues, this is not the best choice for that. Sublingual, it's put under the tongue, it dissolves and it is absorbed through the skin under the tongue. Subcutaneous injection, it's injected under the skin, subcutaneous. When I had a couple cats who were diabetic in the past, and we gave them subcutaneous insulin injections. It's really easy to do on a cat because their skin is kind of loose, and you just lift up their back of their neck and inject it. It doesn't hurt at all, which is really nice. They don't like it because you are doing something to them, but it's a lot easier to do that than some other things. It's a lot easier to do that than to give them a pill sometimes, and you don't usually get bit. Intramuscular injection, it's injected into the muscle. Intravenous into the vein, that usually requires injections usually require some training, even though people can do injections on their own. Intravenous injection usually requires specific skills, so someone who can start an IV. A lot of times if people are having to get regular intravenous injections, they'll install a port, so it's a little bit easier to do that. Inhalation, some vaccines are available in an inhaled form. The flu vaccine is available in an inhaled form. And people that I worked with one person who would just faint every time they got a flu vaccine. And so they would get the inhaled version just to make it easier and easier on the people that had to wake them back up after they fainted. And then there are other medications like inhalers and nebulizers that are giving you inhaled medication. Topical medication, so gel, cream, spray, liquid that's applied to the skin topically. And suppository, it's inserted rectally and it is absorbed in that way. So sometimes if people are having some kind of reaction where they're having a lot of vomiting, they can't really give them oral medications because they'll just barf it right back up. And so they give them a suppository, and a lot of times they give them the anti-nausea suppositories to keep them from barfing stuff back up. So it's just another way to administer drugs. Each one has its own drawbacks and advantages. So it's nice to know like which things are easy and which things are harder, and what are the advantages and disadvantages of each method. So drugs can be taken, some drugs can only be taken via one route. So there's some oral medications that can only be taken orally because they have to be absorbed from the stomach or intestine, transported to the liver, transformed in some way by the liver, and then released into general circulation. Some things can only be given by intramuscular injection because they need to be gradually absorbed into the blood and then transported by the bloodstream. So it depends on what happens to the drug when it gets into your body. And that's what pharmacokinetics studies is how does it move around the body and what needs to happen to it in order for it to be effective. A lot of drugs act by having some effect on the receptors in our cells. So our cells have a ton of receptors for all our different little neurochemicals that are floating around our body and doing their jobs. A lot of times drugs stimulate receptors directly. So a drug goes in and basically takes the place of something else that would have bound to that receptor in the body. Drugs might block a receptor site for normal chemicals of the body. So an example of a drug that stimulates a receptor directly is when someone is on insulin, injected insulin, either because they have type 1 diabetes and they can't make it themselves, or they have type 2 diabetes and they have diminished insulin. And they're on insulin, and the injected insulin goes and takes the place of the insulin that your pancreas isn't making and binds to that receptor site so that it stimulates the receptor directly. Carbidopa levodopa is a drug that's commonly taken for Parkinson's. It crosses the blood-brain barrier, and then it gets transformed into dopamine, which then acts directly on the dopamine receptors. But you can't just take dopamine because it can't cross the blood-brain barrier. And so they have to have another form, and carbidopa levodopa is the form that they use. The drugs that block the receptor site for normal chemicals of the body, an example of that is there's an anti-smoking drug that's called Chantix. And what it does is it blocks the receptor site for nicotine. So people who have a nicotine addiction, they take Chantix, it blocks that receptor site, and then the nicotine doesn't have the same effect on them and allows them to break their addiction to the nicotine, basically. So a couple people have told me that when they were on Chantix, they had really weird nightmares or dreams, like really weird, vivid dreams. And I thought, that's interesting. Because a lot of the receptors in the autonomic nervous system are nicotinic receptors, and I just thought that was, interesting tidbit. The specificity of the drug is dependent on the mode of action. So if it's one that stimulates receptors directly, it's going to be pretty specific for what it's replacing. So insulin or dopamine or whatever. Drugs that interact with several metabolic pathways or common functions are likely to have greater side effects. So that makes sense because there's more things in the body that can affect. If you have a drug that's only stimulating a certain receptor, it's going to have that effect. If you have a drug that can interact with a lot of different things, and there are a lot of our cells have tons of receptors for things that you wouldn't even think that they would have receptors for. Like many of our cells have estrogen receptors. And so if you're female and you have estrogen, running through your body on a regular basis, it's having a lot of effects on different cells. So then you go through menopause and you don't have as much estrogen anymore, and those cells aren't doing the same thing that they used to do before. So a drug that interacted with those receptors would have a more widespread effect and might be likely to have greater side effects. Hopefully that makes sense. So all drugs are potential poisons, depending on a number of factors, how it's used. So it's really important for them to determine the correct dose or the dosing level so the therapeutic effect can be balanced with a possible toxic effect. So what they usually try to do, and this isn't just with drugs, this is with other types of treatments too, but you want to establish the minimal effective dosage where you get the desired positive effects with a minimal potential toxic effects. So it's the same thing when we're doing physical interventions with people. We want to do the minimal effective dose. We want to do the amount that's going to make a difference without causing problems. And it's like when you're exercising, you want the minimal effective dosage. You want to do the amount that gets you the results that you want without causing injuries and strains and things like that. So the idea of minimal effective dose doesn't just apply to drugs, it applies to a lot of other things too. But it's very important in the administration of drugs for diminishing the potential for toxic side effects. So there are lots of things that can affect your drug response. Time effects, when you administer it, time of administration, the onset of the response, how long does it take for the drug to go through its parts of the body that needs to before it's effective, the cessation of effect, how long does it last, the peak effect, when is it at its peak, before it starts to die off, the duration of the action, how long does it last, latency to effect, so that's like the time that you have to wait until it kicks in, and the threshold level, like what is the point at which you start to feel the effects of the drug. And depending on the drug, it might not be something that you can feel the effects of. But a lot of times when I'm working with people with Parkinson's, they'll come in and they'll say, oh, I just took my Cinemet half an hour ago, and so it's just starting to kick in. And they usually notice the effects by how they move. So whether their movements are easy or difficult. So that time is part of the effect of drug responses. There's also some variability. So the chemical properties of the drug, the toxic effects, liver and kidney disease, absolutely. If you have liver and kidney disease, it is going to affect how you respond to drugs. Your age, young or old, your genetics of just what you got dealt, your gender. So females respond differently than males to different drugs. Metabolic cycles, where you are in your lifetime for metabolic cycles, and your overall health. If you have good overall health, you're going to have less variability. If you have a lot of comorbidities, you're probably going to have more variability in drug response. So I was doing a webinar on a different subject, but they were talking about gender, male versus female, and if you have someone who's transgender or non-binary, whether you use male or female, and whether you use the norms for one versus the other. And so if you have a transgender person and you're looking on drug responses, you're going to look at what they're genetically. So if they're genetically female, you're going to look at those for drug responses. If they're taking hormone replacement, if they're doing gender affirmation surgery or taking hormone replacement, you might have to look at for vital signs and blood tests and things. You might have to look at that instead of looking at what their genetic gender is. So it's a crazy world out there. Lots of stuff going on, but you should know this stuff so you're aware of what's going on with your patients. So toxicity can be affected by the physiochemical properties of the drug, the routes and the rates of administration, the rates of absorption, biotransformation, that's what the liver does, and excretion. So if any of those are changed, you might get into a toxic level of the drug. Prescriptions are a legal signed document, and they have to include the patient's name, address, and age, if the age is significant, and usually it has your age on it. The prescriber's name, address, and they have a unique DEI, drug enforcement identification number, the date the name and the amount of the drug, the dosage, the delivery route and directions for using the drug, and the permission for additional quantities. So if you get any refills, and but usually the refills by a certain date. So in the state of Washington, for about the last 20 years, you have to have a printed document. It can't be handwritten, and that's in the effort to reduce errors in prescription. So it has to be a printed document. It can't be a handwritten document anymore. They might write you a handwritten prescription for PP, but they can't write you a handwritten prescription for drugs. It has to be printed. So each drug has a generic name, a trade name, and a chemical name. So the generic name is a unique, official, simple name for a specific drug. So this is the example for aspirin. And ASA, or acetylsalicylic acid, is the generic, unique, official, simple name for aspirin. The trade, proprietary, or brand name, the trade name is aspirin. You might have a brand name, like it might be Bayer aspirin, or other brands of aspirin, St. Joseph's aspirin. I couldn't think of another brand for a second. The chemical name is the chemical component of the drug. And so for aspirin, it's easy. It's acetylsalicylic acid. For some of the other ones, those chemical names, like, holy cow, those are long. I'm not going to read them out to you. But this is one of my favorite little green and white tables from the book. So it has some examples of generic, trade name, and chemical name. So usually the trade name vary because different manufacturers make the same drug. So a good example is ibuprofen is the generic name. Trade name is Advil, Motrin, or Ibrin. They're all ibuprofen, but those are 3 different manufacturers that make that. And the chemical name is over there. I'm not going to read it to you. And hydrochlorothiazide, another common drug. It's a diuretic. It's used for high blood pressure, and lots of different trade names. But they're all the same chemical name. So it's all the same drug. So the trade name depends on where you get it, which manufacturer makes it. And diazepam, generic name, trade name, Valium, Vivol, Diastat, proprietary to the company that makes them, but they're all the same chemical. So the drug nomenclature can kind of be confusing, but a lot of times the generic name is the one that's more often used, which I don't know, that I think that simplifies it a little bit, because you can't be spouting off those chemical names. Well, you can if you want to, but it's a little easier to have the generic name. And but some drugs are known by their trade name. Usually whenever there's any ibuprofen, I call it Advil, just because I do, you know. So like acetaminophen, Tylenol, it's the trade name. Um, the generic name is usually less specific to company. So in the US, drugs are regulated by the US Food and Drug Administration. The FDA regulates the production, labeling, distribution, and other aspects of drug control. In Canada, it's the Food and Drug Directorate. There are drugs that are considered to have a high risk for potential adverse side effects, abuse, or dependency, and those are called scheduled drugs. And there's some restrictions on how they're prescribed and how you can get them. Over-the-counter drugs, OTC, over-the-counter, are available without prescription. Just because something's over-the-counter doesn't mean it doesn't have bad side effects. So a lot of people say, oh, well, it's natural, or it's over-the-counter. It could still have bad side effects. And your OTC drugs can interfere with your prescribed drugs. You can have some of those drug interactions that you don't want. So it's a good thing to know. When you go to the hospital, a lot of people are talking to you when you go to the hospital. One of the people that comes into your room is someone from the pharmacy, and they ask you every little thing you take, whether it's vitamins or Zyrtec for allergies or whatever, any over-the-counter things you take, any prescription medications that you take, any vitamins or other things. and that all goes in your medical record. So the over-the-counter drugs, just because they're over-the-counter doesn't mean that they aren't going to have an effect on the other drugs you're taking. There's a thing that's called off-label drug use, and off-label drug use is drugs that have been approved for a specific disease or condition, but they can be used for something else as well. So this is the example from the book. Hydroxychloroquine was approved to prevent and treat malaria, rheumatoid arthritis, and lupus. So those three things are very different, different systems. Malaria is the blood system basically, or and the liver. Rheumatoid arthritis is the integumentary or the joints. And lupus is the immune system. All three different things being treated by one drug. Another example of off-label drug use is Ozempic, which is a drug that's approved for use in diabetes. People are using it for weight loss. So it's not something that was the approved specific disease or condition that it was developed for, but it's being used for something else. So there are pluses and minuses of that.